On behalf of PHA Canada and HeartLife, welcome to our webinar on understanding pulmonary hypertension in left heart disease. Our partners at HeartLife weren't able to join us today, but they did send us a short video. So to begin, I'll pass it over to Kimberly Burnell to give everyone a brief introduction to HeartLife and PHA Canada.
Thank you, Robin, and thank you all for coming today. My name is Kimberly Brunel, and I am the Director of Programs at PHA Canada. And I'd just like to tell you a little bit about who we are. And then, as Robin mentioned, our friends at HeartLife were unable to join us today, but I will play a short video once I wrap up. So PHA Canada, if you don't know who we are a national health charity led by a diverse and dedicated team of directors, staff, and volunteers. And if you can't tell, we love purple. We are a united family of PH patients, caregivers, healthcare providers, and supporters. We also really enjoy putting PH over any F word that we possibly can. So use your discretion with that. We like to work together in urban, rural, and remote areas wide across Canada, and we like to speak in both English and French. There are over 24 specific PH specialized centers across Canada, and they help us in the diagnosis and treatment of pulmonary arterial hypertension and CTUFs. You'll notice that those in this map across the country. We like to empower the Canadian PH community through support, education, advocacy, awareness, and research. And we do all of this really to better the lives for all Canadians affected by PH. I love seeing all of these wonderful purple faces. So PHA Canada, is committed to working with and for all Canadians affected by PH, and we are really proud to be the national voice of Canada's PH community. We strive to represent and engage those affected by PH in every corner of our country so that they feel heard, informed, and supported no matter where they live. And we do this in a number of ways. If you're looking for support, we have lots of it. If you want to join us every last Thursday of the month, we have what we call monthly virtual meetups. It's just a great opportunity to come and meet other patients from across the country. It's very informal and it's free. Come and join us. We have one next Thursday. If you're looking for a more direct connection, I encourage you to try out our PH Buddy program. And there are lots of other in-person and virtual support groups that you can access through our website. If you are a Facebook friend, I encourage you to check out the Canadian Friends Facebook group. If you're looking for information, our website is the best place to land. If you're looking for information on PH, disease management, mental health, and a list of other pieces of information, I would encourage you to go there. If you're newly diagnosed, please check out our Navigating PH guide. We do several webinars throughout the year just like this, and they're usually recorded and made available on our YouTube channel. And we host an annual community conference, which I'm thrilled to say will be next fall in Vancouver, BC. So we hope to see some of you there. There are so many ways that we like to communicate with you and that you can stay in touch with us. Go to our website to sign up for a subscription to our biannual magazine called Connections. You can get weekly and monthly emails from us through our electronic newsletter called The Pulse. And there are just so many wonderful stories produced by our patient community that you can find on our website. We are almost at a very important time for us in the PH community, which is November Awareness Month. I hope that you'll join us this year in whatever way that you can. Join us on the 22nd of November for our 6-minute walk for breath. Request an illumination in your community. Paint your city purple. Join us in our Time Matters advocacy campaign, which I'll talk about in a moment, and just spread awareness about PH to your friends and your family. You can also join us as we celebrate World PH Day on May 5th and Rare Disease Day on February 28th. We need your voices more now than ever. There is a new drug on the market called sotatercept. It is a new treatment for our patients with pulmonary arterial hypertension and is really a game changer for these patients in our community. Our current advocacy campaign called Time Matters is calling upon our provincial governments to make this drug publicly funded as soon as possible so that all of our patients can really benefit from this life-saving medication. Go to our website or advocacy webpage. You can send a letter to your Minister of Health, share it with friends and family, and if you're really feeling eager, get an appointment with your local government representative and tell them why we need this. We also do a lot of work in research. If you want to learn some up-to-date information on PH research or access to clinical trials, visit our website. We are very involved in the Canadian PH Registry. We offer research scholarships to support PH research across Canada and have produced several reports on the impact of PH on Canadian patients, and you can find those on our website as well. With all that said, I tried to make that as quick as possible. I'm so thrilled that you're here. If you want any information, please visit our website, and my email is there. You can always reach out if you need support or any information, and I just look forward to hearing from you. So thanks, Robin, for the opportunity. As I mentioned, Mark from HeartLife could not be with us today, but I will just start this video on his behalf.
Hello, everyone. My name is Mark Baines. I am the co-founder of the HeartLife Foundation, personal lived experience of heart failure, heart transplant recipient, and passionate advocate. I'm so sorry I couldn't be there with you today in person, but I look forward to watching the recording and hearing all the amazing content, and we'll be there next time. The HeartLife Foundation is a patient-driven charity. Our mission is to really improve the quality of lives of people living with all cardiovascular disease by engaging, educating, and empowering a community to create lasting solutions and ultimately live a better quality of life, something that we all, of course, want. How do we do that? We engage, we educate, and we empower. And you'll probably hear me say that a few times in the next few minutes here. We engage people with lived experience, patients, caregivers, societies, healthcare providers, industry partners, so all major stakeholders involved in cardiac care. We educate informally and formally through Facebook support groups, Zoom meetings, webinars, HeartLife Academy, and resources we offer. Ultimately with the goal to empower, bring the patient voice to the table, make sure it's amplified, that there's nothing about us without us. As I mentioned, we do some informal education. That's for our patient caregiver support. So anyone living with cardiovascular disease across North America can join our Facebook group, patient or caregiver. And we also have weekly Zoom meetings, Tuesdays for individuals living with advanced heart failure care and transplant. And then our Wednesday meetings, which have been going strong since 2020, really where people just come and have a conversation. So they know there's a community around them, that they're not alone in this journey. And we talk about anything and everything. It's a really good time. We have formal education, and this is really, I mean, it came from our patient journey mapping exercise where we realized that there was no real patient-facing education by patients for patients in the community. What started off as heart failure formed into this all-encompassing organization that now covers topics like amyloidosis, hypertrophic cardiomyopathy, connected conditions such as diabetes and heart failure, for example, hypertension and heart failure. So really we listen to our members, our audience, and say, what can we support you with? Last year, we distributed almost 30,000 pieces of material that went into heart function clinics, hospitals, family physician offices, and pharmacies, and we continue to grow that to date. Our most formal piece of education is HeartLife Academy. This is where we bring in the expert opinion, someone like Dr. Ricky Turgeon talking about guideline-directed medical therapy, or a physician who's a specialist in kidney care and heart failure, talking about really that disease, but then also bringing in patient partners to share their experiences. All this is available on heartlife.academy and free for anyone really to join, to learn from. We also have courses on patient and caregiver advocacy, so how you build and support yourselves and your families while you're going through your journeys. HeartLife as an organization, we try to advance global advocacy. I mean, start in Canada, but work our way through. It started with our patient journey map, where we were able to learn the lived experience of heart failure, then really understand needs and opportunities of people from coast to coast to coast. We then developed a patient charter, really to support the needs, to create that sense of what matters for patients and what are our rights as individuals, which is really disease agnostic. And then we went into some policy work. The charter itself, which is ultimately disease agnostic, if you look at it, can be found on our website, was translated into 17 languages, endorsed by 33 organizations worldwide. And really, again, it says that, patients deserve an accurate and timely diagnosis of heart failure. Could be any disease. Support for mental health. Access to timely medications and innovations. Again, really disease agnostic, but really there to support patients and caregivers through their care. What we did then is said, how can we really form this into policy change. And I'm not going to get into the details in this short amount of time, but maybe a presentation for the next webinar. We developed an economic framework based on the charter items. So we worked with the Institute of Health Economics to really quantify the qualitative items. So we developed policy recommendations around diagnosis and screening, management of care, as well as research and evaluation to involve patients. We did a day on the Hill. Senator Yona Martin in the middle there represented us, brought us to the Hill, and ultimately put forward a private members bill, Bill S204, based on our framework to establish a national framework for heart failure. This is in its first reading, hoping to have its second reading this fall, which we're really excited about. It'll be the first time that Canada puts together a national framework for heart failure. We don't work alone. As an organization to support the Canadians across the country, we work with so many organizations. Partnerships are key in everything we do, and we wouldn't be able to do it with the support around us. These are my people. That's my daughter, Mara. A little outdated. She's just over 2 now, and that's my wife, Jessica. Her t-shirt is on purpose because we like to say that it's about life, not failure. If anyone has any questions, feel free to reach out to me, Mark, M-A-R-C, at heartlife.ca. Happy to share more information on how we support individuals across the country living with cardiovascular care. Thank you and have a great rest of the webinar.
Thanks, Robin.
Hey. Thanks, Kim. Now I'd like to introduce Dr. Lisa Mielniczuk, our presenter today. Among many other impressive credentials, Dr. Mielniczuk completed her medical degree at McMaster University, a residency in internal medicine from Queen's University, and a cardiology fellowship at the University of Ottawa. She's an active leader for the heart failure and pulmonary hypertension community and is a past chair for Pulmonary Hypertension Association of Canada. Dr. Mielniczuk is a translational scientist with more than 100 peer-reviewed papers. She's currently a faculty member at the Mayo Clinic, where she's continuing her research and clinical work in heart failure and pulmonary hypertension. So over to you, Dr. Mielniczuk.
Thank you very much, Robin. I will just share my screen here. There it is. Excellent. Wonderful. Very nice to be here this afternoon, and thanks so much for the invitation to speak here today. It's really nice to hear what Mark was saying and what we've heard all about PHA. And all the work that PHA Canada does. And I really think that this topic is the perfect marriage between organizations like PHA Canada and HeartLife, because pulmonary hypertension and left heart disease is a disease that affects people who do have heart failure. And it is something I think very important and relevant to patients, to families, and to healthcare providers in both of those realms. So what I thought I would do, and I'm cognizant of the time, it's about 2:45 where I am, and I want to leave lots of time for discussion today. But what I thought I would talk about is really kind of a very contemporary overview to our current understanding of what pulmonary hypertension is and left heart disease, and try to conceptualize it in a framework of, well, why do patients get this? How does it happen? Who's at risk of getting it? And really, what are the approaches that we take in trying to understand this disease? And I am going to spend a few minutes talking about the management of this disease, because frankly, I think this is where some of the most exciting stuff is. And as I say, I do want to leave lots of time for questions. So for those that may be joining us that don't yet have a lot of familiarity of what pulmonary hypertension is, pulmonary hypertension is not a single disease. It's a classification of disease systems, really based on shared origins of disease. And so at a very high level, we can think of 5 separate classifications of diseases. And I often say to my patients, pulmonary hypertension may be due to a heart condition, maybe due to a lung condition, maybe due to chronic thromboembolic disease, or maybe due to a primary problem with the blood vessel that are inside the lungs or connecting the heart and the lungs themselves. And oftentimes people think that pulmonary arterial hypertension is a rare disease, and group 1 disease is a rare disease. But what I hope I leave you with today is that the idea is that pulmonary hypertension in left heart disease is not at all rare. In fact, it's very, very, very common. So how common is pulmonary hypertension? Well, when you look at global estimates across the world, you can see that most of the pulmonary hypertension that is being diagnosed and managed is that is caused by left heart disease or lung disease. And this is certainly the most common thing that we see as clinicians in the field. In fact, it is so common that it's estimated that about 1% of the entire prevalence of the population will have a diagnosis of pulmonary hypertension. Now, if you go into the cohort of patients who are over the age of 65 years, that prevalence increases to 10%. And the far majority of that is due to underlying left heart disease. And so you may be wondering, well, I've been diagnosed with heart failure, or I've been diagnosed with a heart condition. I know someone with a heart condition. Who's at risk of getting pulmonary hypertension from left heart disease? Or perhaps you're looking at it the other way. I've been told that I have group 2 pulmonary hypertension. What part of my heart caused that? And there are many different conditions that can cause PH in left heart disease. It can be caused by a valve problem. It can be caused by a structural problem with the lining of the heart. We call that the pericardium. And most commonly, it's caused by a heart muscle problem. It's either caused by impairment in the pumping function of the heart or impairment in the relaxation of the heart. And that is almost certainly something we see about 90% of our cases. And it is so important. We're going to spend a lot of time talking about that. Well, Mark's already talked a little bit about this in his video, but how common is heart failure? Well, we know that heart failure is increasing in prevalence. In fact, it's estimated that between 2014 and 2030, the prevalence of heart failure in the United States and also in Canada, but this is US data, is going to increase by 46%. And in fact, in that prevalent case of heart failure, about half of all of those patients have a diagnosis of heart failure with preserved ejection fraction. Now, I bring that up because it is such a common disease, but we believe that a very significant component of patients who have heart failure with preserved ejection fraction will get some pulmonary hypertension. Now, how common that is really depends. It depends on the population of patients that are being sampled. It depends a little bit on how we're defining pulmonary hypertension. And it depends on what methods we use to diagnose pulmonary hypertension. But you can read estimates that anywhere from 40 to 80% of patients with a diagnosis of HFpEF, or heart failure with preserved ejection fraction, will have group 2 pulmonary hypertension. And we know that if you have a diagnosis of heart failure with preserved ejection fraction or any type of cardiac disease that results in pulmonary hypertension, we know that these patients have worse quality of life. They have a higher risk of being admitted to hospital, and they have a higher risk of other adverse outcomes. And so it's a very important marker of disease progression, and so therefore a very important marker of treatment. Now, we're going to spend a lot of time on diagnosis and treatment, but I'd like to take a sort of an overview approach to why patients with left heart disease get pulmonary hypertension. And if you've ever talked to your clinician or done some reading about this, you understand that the heart and the lungs are in a continuous circuit. And in any continuous circuit, when you have elevated pressures in one part of that circuit, the pressures will increase in a backwards fashion. And so in left heart disease, any condition that causes abnormalities in the pressure of the left ventricle. So if you can see my pointer, I'm not sure on your screen, but if there is abnormalities to the bottom chamber of the heart, either the heart is too stiff, as in HFpEF, or the heart muscle is weak, the pressures inside the left ventricle will increase. And those pressures get transmitted backwards into the left atrium, the top chamber of the left side of the heart that pumps blood down into that ventricle. And if those pressures are increased, then it causes elevation in the pressures of what we call the pulmonary veins, the veins that drain the red blood from our lungs into the left side of our heart. And that causes what we call pulmonary venous hypertension. And if those pressures are elevated for a more significant or prolonged period of time, we then get backwards transmission of pressures in the pulmonary arteries, the vessels that contain the blue blood leaving the heart, going into the lungs. And now we know the right side of the heart has a very important job. It has to pump that blue blood into the lungs. And if the downstream pressures are high in the pulmonary arteries, that right heart has to work harder. And the right heart often suffers, gets fatigued, and patients can develop the symptoms of right heart failure. And so any condition where there's abnormal pressure inside that left side of the heart can result in this backward transmission of pulmonary hypertension and, unfortunately, right heart failure. Now, we talked a little bit about this already. Any condition that can cause impairment in that left side can cause pulmonary hypertension. So we talked about heart and valve disease, common types of valve disease that you or someone you know may have been diagnosed with, are things like aortic stenosis, mitral stenosis, or mitral regurgitation. And again, we see those cardiomyopathies, reduced heart failure, or preserved heart failure. Now, the understanding of pulmonary hypertension and left heart disease has really accelerated substantially over the last 10 or 15 years. And I always find this slide, it's a bit dated now, but I find it very sobering because, in fact, we didn't even start thinking about pulmonary hypertension in left heart disease until 2008. That wasn't that long ago. And since 2008, we've gone through multiple iterations of how we understand and classify this disease until our current understanding, which I'll share with you in a minute. But when we see patients in pulmonary hypertension clinic, one of the most important jobs that we have is, and I say to our patients, there are three main questions that we have to address. The first question is, do you have pulmonary hypertension? And then the second question is, if you have pulmonary hypertension, why? Because, as we've already talked about, there are different causes. And then the third most important question is, how are we going to treat this? And what does this mean for you in your life? And what should you be thinking about in the next 6 weeks, 6 months, and 6 years? And so when we talk about pulmonary hypertension in left heart disease, we're talking about this very specific disease we call group 2 PH. And there are certain clues that can help us to understand if, in fact, patients have group 2 pulmonary hypertension versus group 1 or group 3. And so we take an accurate history and we listen to the different diagnoses that patients have had. We use things like echocardiogram and heart catheterization, and we'll talk about that in a few minutes, as ways to confirm our suspicion and help, and we use that to help guide our management. Well, let's start by talking a little bit about the echo. Maybe many people on the call have had an echo, or they know a lot about an echo, also called a cardiac ultrasound. It is the best non-invasive way of suggesting a patient has pulmonary hypertension. And this slide here just gives you just a small idea of the different measurements that can be taken to help to come up with a probability of whether a patient has pulmonary hypertension. And that's very important for question number 1. But it can also help us address that question number 2, which is why? Why might this patient have pulmonary hypertension? Because, importantly, we're looking for things like abnormalities in the heart valves, abnormalities in the left-sided function of the heart, or the size of the left atrium, that top chamber in the heart, that might give us suggestion that that pulmonary hypertension is actually due to left heart disease. And there are certain clues that we specifically look for when we're trying to answer question number 2, which is, why does that patient have high pressures? And I tell my trainees and my junior colleagues that anytime we see these abnormalities, specifically left-sided heart valve disease or stiffness, which we can measure on the echo, or enlargement of that reservoir chamber, we call that the left atrium, then the probability that that patient has group 2 pulmonary hypertension is very high. And that's really, really important. And this is a slide that actually comes from our current guidelines, the European guidelines for the management and diagnosis of pulmonary hypertension. And I only bring this up because, again, it provides to us an understanding of how we use these diagnostic tests to help to sort out why a patient has pulmonary hypertension. And so if you've been to a PH clinic, you've probably been a bit frustrated with all of the tests that are done and perhaps sometimes even redone, yeah, before you get to, come to that diagnosis. And I can assure you that all of these tests have value. They help us to come up with what we call a pretest probability of where that pulmonary hypertension is coming from. But not only that, they can also help us to understand how worried we need to be about that patient. And there are certain features on some of the history, some of the non-invasive testing that we do, such as echo or exercise test, where we know that certain parameters will increase a patient's risk for having issues or concerns in the short term. And so these patients are often treated more aggressively. But ultimately, if we really want to understand the cause of the pulmonary hypertension and to confirm the diagnosis, we have to do a right heart catheterization. And perhaps many on the call have had a right heart catheterization. It is a minor procedure where we pass a catheter down through the right side into the right side of the heart, oftentimes through the internal jugular vein, or sometimes from the vein in the arm, or even a vein in the groin. And it will not just suggest pulmonary hypertension, but it will accurately and definitively measure those pressures. And we have thresholds where we can use to say, yes, this meets the threshold for pulmonary hypertension, and yes, this meets the threshold for group 2 disease. And the slide on the left just I often get this question, well, is echo good enough for right heart cath? And you can see that if you correlate echo measures, estimates of pulmonary pressures, with invasive measures of pulmonary artery pressures, most people fall in a very, very good correlation. But there is a significant amount where that echo could even overestimate or underestimate the right heart catheterization. And so this is why right heart cath is essential in what we call the gold standard. Now, right heart catheterization measures the pressures, as I've already talked about. And to say definitively with confidence a patient has pulmonary hypertension, we want to see that mean pulmonary pressure over 20. Now, we're not here today to talk about pulmonary arterial hypertension, but the main difference between group 1 disease, pulmonary arterial hypertension, and group 2 disease, pulmonary hypertension from left heart disease, is that measurement of the left-sided filling pressures. That if those left-sided filling pressures are low, then that suggests the patient does not have group 2 PH. And if those left-sided filling pressures are high, then that does suggest that group 2 pulmonary hypertension is the source of their PH. I'm going to start, and those are some of the other thresholds that we use to look at different types of group 2 disease. So I've talked a little bit about the role of echo and the role of the cath in making the diagnosis, but there's also some interesting things we're seeing more recently in the last few years, which is sometimes patients come to us with shortness of breath and their resting right heart catheterization may look completely normal. And we're learning more and more that sometimes we have to unmask a diagnosis of pulmonary hypertension, and we can unmask a diagnosis of group 2 pulmonary hypertension with either exercise or by giving some fluid in the context of that heart catheterization. And this may be a way to help us to really understand, in particular, patients who have group 2 pulmonary hypertension from what we call heart failure with preserved ejection fraction, that very, very common condition where the heart pumps well but doesn't relax well. And this is, I think, an important job for clinicians who treat pulmonary hypertension and treat heart failure, because I think we would all agree that one of the most common reasons our patients don't feel well is because they get short of breath and they have what we call exercise intolerance. They feel okay when they're not doing anything, but when they start to do the things they want to do, they get tired, they get short of breath, and they feel weak. And in patients with group 2 pulmonary hypertension, that is often because of these abnormal pressure volume relationships that are happening in that left side of the heart. And they may be mild when the patient is at rest, but when the patient starts to exercise, even if it's just going up a flight of stairs, For some people, it may just be doing activities of daily living, having a shower, washing some dishes. The heart beats faster, the heart has to work harder, and those pressures inside the chamber, they go up and up and up and up until that patient has to stop. And we can now identify that with certain maneuvers in the right heart cath to help understand that exercise intolerance. And this is very, very important. So, if we've gone through question one, does the patient have pulmonary hypertension? And we've talked a little bit about question two, which is the role of the right heart catheterization, perhaps at rest or even with exercise, in coming up with a diagnosis of group 2 pulmonary hypertension. We have to ask about question three. How do we treat it? If we truly believe a patient has group 2 pulmonary hypertension, how is it treated? And this is very critical because group 1 disease, pulmonary arterial hypertension, is treated very, very differently than group 2 disease. And in our patients with group 2 pulmonary hypertension, we have to do two things. We have to treat that left heart disease. We have to do everything we can to treat the left heart disease. And what we've tried to do, and many, many people have tried to do this over time, is how do we treat the pulmonary hypertension? How do we treat not just those high pressures, but the remodeling that happens inside the pulmonary veins and inside the pulmonary arteries? How can we treat that to try to lower those pressures and help our patients to feel better? And so when we talk about management, I'm going to contextualize it in those two ways. This is a busy slide, and I only put it up for your reference, but also to kind of share with you what the most current and contemporary expert opinion is on how we treat group 2 pulmonary hypertension. And anything that is a class 1, what you see in green, that would be considered a strong recommendation that every clinician should be offering to their patients. And you can see that one of the most important things is that we should be treating the left heart disease. And so this is really a disease of heart failure. And this is why it's lovely to have collaborations with HeartLife, because many patients with heart failure, particularly HFpEF, have group 2 pulmonary hypertension. And the guidelines tell us a little bit about when and how to use diagnostic testing. Now, anything in red, down here, a class 3 recommendation. This means that we shouldn't be doing this. And what you can see is very clearly that drugs that are approved for group 1 disease should not be used in group 2 disease. And that's really, really important. And for those that have pulmonary arterial hypertension, or who have read about PAH, you know that there are 4 different pathways of different types of drugs that we can use to try to reduce the remodeling that patients get in the pulmonary arteries. One of the newest pathways, of course, is that activin pathway with the drug sotatercept that you heard us talk about a few minutes ago. These drugs are fantastic in group 1 disease. People feel better. The pressures come down and they live longer. And so we want to be able to use these drugs in group 2 pulmonary hypertension. But unfortunately, every time we have tried to use these drugs in group 2 pulmonary hypertension, we have failed to consistently show that patients will feel better. In some studies, patients have actually felt worse. And this is why at present, in 2025, the recommendations are still that we should not be using these medications to treat group 2 pulmonary hypertension. Now, does that mean that we never do it? No, it doesn't mean that we never do it. In fact, your clinician may very carefully use it in very certain and specific circumstances, and that's okay. That's a conversation and in very specific case by case methods. But overall, we really need to work harder to understand how, when, and if these medications can be used. Now, It was mentioned about sotatercept, a very exciting drug in group 1 disease. And so people are still trying to understand this. The needle is still moving forward. In fact, there's a study that's just about finished called Cadence. And Cadence is looking at the effect of sotatercept in group 2 pulmonary hypertension. And I'm very excited about this. I'm hopeful that this will be the study that changes the history of group 2 pulmonary hypertension therapies. And we're going to know more about this in as early as probably the first or second quarter of 2026. So stay tuned, because if this is a win for our patients, this will be very, very exciting. So with all that to be said, if we can't use PAH medications to treat group 2 PH, how can we treat these patients? And this is where I think it gets exciting, because some of the very exciting therapies that are used in heart failure with preserved ejection fraction may actually have a benefit on the pulmonary vasculature, on the right side of the heart, in ways that could really help patients with group 2 pulmonary hypertension. And I'm going to skip through this just because I know that I do want to leave lots of time for questions. But in a condition like heart failure with preserved ejection fraction, there's been lots of different therapies that have been studied for these patients. And like group 2 PH, many of these therapies historically have not shown to be of significant benefit until recently. And one of the things that's evolved in our understanding of group 2 PH, and particularly in HFpEF patients, is that not every patient is the same. And we see different types of clusters of patients with similar risk factors, with similar types of disease proces. And when we understand that, we call that phenotyping, and use specific treatments to specific types of group 2 PH or specific types of HFpEF, we are now starting to see some promise. In fact, this slide is just hot off the press. The Canadian Cardiovascular Society released their new guidelines for the treatment of heart failure with normal ejection fraction just this past week. And it's going to be presented at their meeting that's coming up in Quebec City. And really, what it says is that all patients should be on something called an MRA, mineral corticoid receptor antagonist therapy, and an SGLT2 inhibitor. And in certain conditions, if your BMI is a little bit high or you have higher blood pressure, there are other drugs which also receive not a strong but a weak recommendation for use. And we don't have time to go over this in great detail, but I want to leave you with the optimism that if you've been diagnosed with group 2 pulmonary hypertension from HFpEF, SGLT2 inhibitors are substantial drugs that can reduce your risk of coming into hospital for heart failure or worsening heart failure, and even potentially cardiovascular mortality. And so every group 2 HFpEF patient should have these drugs. And if we kind of put that into a perspective, what's the magnitude of that benefit? This is American data of patients with a diagnosis of HFpEF. And what they did is they said, well, if every HFpEF patient got an SGLT2 inhibitor, how might it reduce heart failure hospitalizations? And so I took this data and I extrapolated it a little bit further. And I said, if every HFpEF patient, if we estimate the prevalence of group 2 PH in HFpEF in the United States, it's probably almost 1 million patients. And if every one of those patients got an SGLT2 inhibitor, we could save 230,000 events of heart failure a year and almost 200,000 heart failure hospitalizations in our group 2 PH patients. That's how profound SGLT2 inhibitors are in these patients. And there are other drugs as well. I mentioned spironolactone. Spironolactone is a drug that helps to reduce the fibrosis and stress hormones inside the heart. And it's a really, really good therapy for patients with heart failure with preserved ejection fraction. And we also believe that it has a beneficial effect on the right side of the heart. And so this is a study called Fine Arts, which was just published in the last year, that again gave us promise for treatment of patients with heart failure with preserved ejection fraction. Now, although none of these clinical trials enrolled specifically patients with group 2 pulmonary hypertension, we know that, as I've already said, most of these patients had group 2 pulmonary hypertension. And so we extrapolate the benefits, these very important benefits of these therapies to our patients with group 2 PH. And probably the newest drug that I just want to talk about is drugs we've all heard about, things called GLP-1 receptor agonist therapies, the Ozempics or the Wegovy's. And these medications are very exciting and have a number of beneficial effects that go beyond weight loss. They have good effects on heart, good effects on kidneys, good effects on vascular function. And so, of course, people are going to ask is, would these drugs benefit patients with a diagnosis of HFpEF and possibly group 2 pulmonary hypertension? Now, again, this study wasn't a pH study, it was a HFpEF study. But obesity and HFpEF are very common. In fact, 80% of patients with HFpEF are either overweight or obese. So this is not a small problem. And when these patients were given drugs like semaglutide or tirzepatide, we see improvements in outcomes. We see patients feel better, they walk more, they have a better quality of life. And yes, they lose the weight. And we've seen this in 2 separate studies of patients with HFpEF and a BMI over 30. Now, again, many of these patients had group 2 pulmonary hypertension. So I want to leave us with the optimism that even though there are still gaps in our knowledge about how to treat pulmonary hypertension due to left heart disease, there is a lot of excitement and a lot of promise about how to treat heart failure with preserved ejection fraction, whereby many of those patients will have group 2 PH. And then the last thing I want to say is we've talked a lot about drugs, but what about exercise? And there may be some questions about exercise. And in fact, there's been so much data on the benefits of exercise in our patients with left heart disease. Those benefits are multiple: better quality of life, better exercise tolerance, better heart function. And so I believe that some sort of exercise training is really critical in all our patients with group 2 PH. And then the last thing, beyond drugs and beyond exercise, there are even invasive techniques that are being studied for patients with group 2 pulmonary hypertension or HFpEF. And if there's time, I'm happy to go over this in more detail. At present, these are all investigational, all preliminary, but promising that not only with therapies, but perhaps minor surgical procedures or ablation techniques may be another role, another avenue of treatment for our patients with group 2 PH. So I'm really happy to take questions, but I do want to leave with that optimism. Our understanding is changed over time. Pulmonary hypertension due to left heart disease is not a rare disease. It's a very common disease, and it's very common in many different cohorts of patients with left heart disease. The diagnosis of this is not always easy, and it does involve the testing we talked about, the echo and the right heart catheterization, and a really good history and physical. And although even in 2025, we are not using routinely drugs that treat pulmonary arterial hypertension to treat group 2 disease, we have a whole new era of drugs that work significantly on patients with left heart disease. And we are hopeful, and time will tell, that those benefits will translate to a reduction in pulmonary hypertension for our patients with group 2 PH. So I'll stop there and happy to take any questions.
Thank you so much for that presentation. I'm going to indulge myself by starting with a question. First of all, I love the abbreviation HFpEF. It sounds like huff and puff, right? It sounds so, I don't know. I'm very fond of it. But what is being preserved and what is being ejected? Like, can you break it down a little bit?
Yeah, for
Like,
sure,
what does
for
it
sure.
mean?
Yeah, so I'll take no credit for the HFpEF acronym. That's a kind of that was a very common term that is used across clinical contexts and research, and it's sort of thought of as HFrEF and HFpEF. And what the difference is what we call the ejection fraction. The ejection fraction essentially is a measure of the pumping function of the heart. And there has been some
moving targets in terms of what is a normal ejection fraction. But most people, for the context of this conversation, would consider a normal ejection fraction to be over 50%. And so if you're under 40%, you're HFrEF, heart failure with reduced ejection fraction. And if you're over 50%, you're considered having HFpEF, heart failure with preserved ejection fraction. And so that's really the distinguishment. And the two types of left heart disease are actually treated very differently. Both of these patients are at risk for getting pulmonary hypertension. But what we're seeing, and why I focused a little bit more on the HFpEF population, is because we've got so many good therapies for HFrEF patients. Those therapies are very effective and very substantial. And yet, as I mentioned, until recently, we didn't have a lot of therapies, Robin, for HFpEF patients. And many patients with HFpEF will get pulmonary hypertension. In fact, the most common type of group 2 PH that everybody sees is group 2 PH secondary to HFpEF. And so it's very exciting to think, well, now we are finally in an era where we have treatments that can actually be used to help patients with HFpEF feel better, have less symptoms, have lower risks of heart failure hospitalizations, which is a very important thing. And although we don't have data to point our finger on and say it works in pulmonary hypertension due to left heart disease, we have good data that it will reduce the symptom burden in HFpEF. And therefore, we extrapolate that since many of these patients have group 2 PH, we now have treatments sort of indirectly for group 2 PH, if that makes sense.
Well, makes sense to me. Thank you. Okay, now we've got some questions coming in the Q&A. First of all, a question from Peggy. Is there a possible correlation with left bundle branch block?
That's a great question. So left bundle branch block is an electrocardiographic finding. It's an electrical finding in the heart where the way the electrical activity spreads through that left ventricle, that bottom chamber of the left side of the heart, is abnormal. So that electrical activation from one side of the left heart to the other side takes a different pathway. And we can see that on the ECG. That ECG is that sort of electrical, those bumps and waves that we see. And when there's a very specific pattern of electrical activation, we call that a left bundle branch block. Now, left bundle branch block, to the best of our knowledge, is not related to pulmonary hypertension. However, people that have a left bundle branch block can have it for many reasons. Sometimes they can have it because the electrical wiring of the heart changes and it gets a bit slower with age. But sometimes it can suggest an underlying heart muscle problem. And if there's a heart muscle problem, either the heart cells are abnormal, they're too thick, or there's some fibrosis there, those electrical currents kind of get delayed a bit as they move through the muscle, and that can cause a left bundle branch block. So if you have been diagnosed with a left bundle branch block, it's probably important that you have an echocardiogram or an ultrasound of your heart to make sure that there's no heart muscle weakness or heart muscle abnormality that's contributed to that.
Okay, thank you. Louise asks, how much can you push yourself when doing exercise? Are you at risk if you overdo it?
It's a very important question, and I think one that we get a lot. What I often tell patients, and this is a high level conversation, I think individual patients should discuss this specifically with their physician or their care provider. But it depends a little bit on how well you are feeling and how well you're doing. But in general, we know that the heart is a muscle. And like all muscles, it will perform better for us if we use it, if we exercise. So exercise is a really good thing. Not only does it help to keep our heart happy, but it also, very importantly, helps to keep the rest of our body happy. And our muscles will be better able to adapt to whatever our heart can provide with exercise if our muscles are in a little bit of shape. So for all those reasons, exercise is recommended. How much is too much? I always tell patients that exercise does not have to be going to the gym and getting a membership. It does not have to be lifting weights. In fact, lifting heavy weights is really not that good for the heart to begin with. But I say the warning signs are anytime you do physical activity, if you start to feel certainly chest discomfort, If you start to feel nauseated or dizzy, those are, or you're so short of breath that you can't breathe or you can't talk, that you're just using all your breath for that activity, and you're feeling uncomfortable with that, that's probably the point where you should slow down. Is it dangerous? It's not necessarily dangerous for most people unless you're not in a stable condition for your heart. Um, but it doesn't offer you very much gain. In fact, what'll happen is if you push yourself too far, you'll either injure yourself or you'll be so exhausted that that it'll actually delay you from getting back into your exercise routine. So, it's much better to have a less of an intense pace and go for a longer period of time. Right? So if you like to walk, if that's your activity, you don't have to walk faster, just walk a little bit more, even if that's just adding a minute or a couple of minutes onto your regimen. And that level of kind of slow and steady gain, that's what really helps, the heart to perform better over time.
Great, thanks. Laura asks, how often should a right heart cath be repeated after diagnosis?
Very, very good question. And it depends a little bit on why that right heart catheterization is being done. Um, as I mentioned earlier, all patients should have a right heart catheterization to confirm the diagnosis when group 1 disease or pulmonary arterial hypertension is being considered. In group 2 pulmonary hypertension, you don't always need a right heart catheterization if you're very confident, or your clinician, your doctor or your nurse is very confident in the diagnosis based on your echo or based on other types of non-invasive imaging that has been done. A right heart catheterization may not be necessary. But if there's any uncertainty to the diagnosis, then a right heart catheterization is essential. Now, once you've made the diagnosis and you've had that right heart catheterization, sometimes the test is repeated to look at how someone responds to treatment. And so sometimes we go down a treatment pathway and we just want to know, has that treatment has it worked? Are the pressures coming down? And so we may repeat the right heart catheterization. Sometimes providers want to repeat it, every couple of years just to sort of see where things are at. But in general, there's no recommendation that it has to be repeated routinely on any regular sense of basis just to look. What I say to my trainees is I'm very thoughtful about the use of right heart catheterization. I think it's a fantastic test. It provides a ton of information, both from a diagnosis standpoint, but also from a prognosis standpoint. However, I ask myself, is it going to change our management? Will the information that we get from this test somehow help us to do better with managing our patient or understanding the problem? And if the answer is yes, absolutely. If the answer is no, probably you want to avoid it because it is an invasive test. And although the risks are very low, there certainly are some risks involved. And so that sort of thoughtful approach, I would suspect is how most of our clinicians operate in Canada.
Thanks. Jeannie asks, is there a correlation between prolonged QT and pulmonary hypertension?
Oh, another good heart rhythm question. So, to my knowledge, there's no correlation with prolonged QT causing pulmonary hypertension or pulmonary hypertension causing a prolonged QT. So, for those that aren't sure, or have never heard of that term, prolonged QT again refers to some electrical activity in the heart, and it's a very specific measurement that's taken on the ECG after the heart has electrically what we call depolarized, and when the electrical forces are in their relaxation phase, there's a time period. It's measured in milliseconds, and that's called the QT interval. And sometimes people can be genetically predisposed to have a longer QT interval. And those people can be at a much greater risk of having abnormal heart rhythms that could be quite dangerous. And that's a very specific and separate condition that has nothing to do with pulmonary hypertension. The only that I can think of that would sort of unite those two things are medications. There are medications, not PAH medications per se, but many other medications, including diuretics, that can cause electrolyte abnormalities or medications that directly affect the QT interval. And those medications can cause lengthening of the QT interval, which can be dangerous. And so, if you're on diuretics or medications where your potassium level is low, that can be a risk for lengthening out that QT interval. And when you go to your pharmacy to review or to pick up medications, your pharmacist, certainly your physician, but also your pharmacist should be aware of drugs that potentially interact and could cause prolonging of the QT interval. And that again is something that should be avoided.
Okay, and looking at the time, this will be the last question. Laura asks, what is your thought on puffers? Alvesco is the one that they're asking about.
So there's lots of different puffers on the market to treat underlying lung disease. I'm not a lung doctor. I'm a cardiologist, so I'm not really I don't want to get too specific about the different types of puffers that are out there. Suffice to say, a drug like Albasco is a fantastic drug. And if you've been prescribed an inhaler or a nebulized therapy or something like Albasco, that is usually done for the treatment of underlying lung disease, which could include something like COPD or asthma or other types of fibrotic lung disease. And these medications are really, really important at helping people to feel better. People who take them, they have less shortness of breath, they can have greater exercise tolerance, and it reduces worsening of the disease over time. How this relates to pulmonary hypertension is important because although we didn't talk about it today, Group 3 pulmonary hypertension is pulmonary hypertension due to underlying lung disease. And not surprisingly, just like everything we've talked about today with Group 2 disease, where the main treatment of Group 2 pulmonary hypertension is to treat the left heart disease, the same principles are seen in Group 3 disease. So if you've had lung disease and your doctor thinks you have pulmonary hypertension because of Group 3 disease, so pulmonary hypertension from lung disease, we want to do everything we can to optimize your lung function and reduce the severity of pulmonary hypertension. And drugs like Alvesco and other types of inhaled therapies are really important to help to treat that Group 3 pulmonary hypertension.
Thank you very much. That brings us to the end of our time today. So I'd like to offer huge thanks to Dr. Mielniczuk for everything you've shared today, and your presentations are always terrific, and this one was no exception. So thank you everybody for attending.